Vijaya to all, and we welcome once again post the festival our esteemed teachers and to our dear students and our co-organizers of Federation of United Doctors. And today our class will be on dermatology by our eminent teacher and dermatologist Dr. Partha Mukherjee, and I hand over the podium to him, and with a sincere thanks from Federation of United Doctors for being with us and for taking this class. Thank you, sir. Podium
Thank you. Thanks to the Federation of United Doctors for allowing me to speak on a dermatological topic. Good evening to all my students and also the senior members of the doctor fraternity who are here. Today I'll be talking on papulosquamous disorders. Now, dermatology, as you all know, is a visual science. Achha, am I audible?
Yeah, you are audible.
Yes, sir. Yes, sir. Yes, sir.
Yes, sir.
Fine. Dermatology, as you all know, is a visual science. Your eyes will have to pick up the clues or various clinical clues which you will see in the patients and knit them up, like putting the pieces of a jigsaw puzzle together and try to come to a confirmatory clinical diagnosis or a provisional differential, and finally, if required, taking the help of a few investigations, biochemical investigations, or at the utmost, histopathological investigations to confirm your provisional clinical diagnosis. But a lot of dermatological disorders are diagnosed by the naked eye basically. So their clinical acumen, clinical clues, you have to sniff them out and come to a confirmatory diagnosis. So today, my topic of discussion is papulosquamous disorders. Papule and squam, these are the two typical terms which make up papulosquamous disorders. Papules are, as you know, are one of the principal primary lesions in dermatology, raised from the surface lesions greater than 1 centimeter in size, and squams means scales. So scaly dermatological disorders presenting with scaly papular elements or scaly papular lesions fall under this group of papulosquamous disorders. Now you may ask, why are we discussing this group of disorders? Basically, amongst the papulosquamous disorders, the top of the list or the most important one, which you will see frequently now as also in your future clinical practice, is psoriasis. Now, psoriasis can be given to you in the form of a short note in your theoretical final professional examination, or we frequently give spot cases of psoriasis in the practical examination. So, trying to diagnose psoriasis, if you have missed your ward lectures or your ward clinics in your 6th and 8th semester, if you can go even see this presentation, it has a lot of photographs. Though I missed out on a few personal photographs yesterday due to some technical glitches, but I have kept some slides. And while I'll be discussing over the next hour and so, I'll be talking to you about the clinical pointers which will help you to diagnose confidently a case of psoriasis. Now let us move to the next slide. So what are the disorders included in papulosquamous disorders? The 3 asterisk marks disorders are the ones which we are going to discuss in the next 1 hour, because these 3 are frequently clinically seen. On the top of the list, as I have already told you, is psoriasis, followed by lichen planus. Lichen nitidus is also a subtype of lichen planus. Pityriasis Rosea. This is very important. You'll commonly see in your clinical practice in future also. Pityriasis rubra pilaris, seborrheic dermatitis, quite frequently seen. Lichen sclerosus atropicus, and Pityriasis lichenoides. Some of these disorders would be difficult for you as final year students to diagnose, where these are our dermatological specialties, but psoriasis, lichen planus, Pityriasis rosea, these 3 which we will be discussing over the next 1 hour are very important short cases or spot cases basically in your final MBBS examination. Now, once again, this is again in a lighter vein. It has been seen that amongst the OPD patients attendees, at least 30 to 35% are dermatological cases. So a good strong base in clinical dermatology will help you, though even if in future you do not aspire to be a dermatologist, but your basic clinical exposure to dermatology would help you to diagnose these common disorders frequently encountered. Now let us move to psoriasis. This is a brilliant quotation by John Updike. I don't think you have heard the name of John Updike. Those who have heard, John Updike is an American novelist, a poet, short story writer, and he has this strange record. He had been nominated and had received the Pulitzer Prize for literature twice. Excellent. Now, John Updike himself suffered from psoriasis. So this is a famous quotation by John Updike. Look, just see the quotation. I am silvery, scaly, puddles of flakes form wherever I rest my flesh. Lusty, though we are loathsome to love. Keen-sighted, though we hate to look upon ourselves. The name of the disease, spiritually speaking, is humiliation. What a wonderful summary of the disease. Such a great psychological morbidity is associated with psoriasis. You just can't imagine. If you see patients, I'll again describe and discuss some of the clinical cases which I have seen in my private practice, where this excellent, rather heartbreaking form of psychological catastrophe had resulted in a lot of feud between family members, even between husbands and wife. This particular case, which I saw in 2014, you can see in the slide. Sorry, the quality of the slide doesn't look so good. You can see a lesion, a scaly lesion over the extensor elbow, and surrounding it, you will find a mehendi decoration. This lady, young lady in her late 20s, I had seen her 6 years back in my private clinic. Just within 2 to 3 weeks of marriage, she was accompanied by her husband to my clinic, and they were both a bit downhill psychologically, a bit on the back foot, because just immediately post-marriage, within a couple of weeks or 3 weeks, she had developed this particular lesion. Well, they were quite apprehensive and were asking me, doctor, what is it? Still, the marks of the mehendi were visible, hadn't been wiped out yet. The classical psoriatic plaque. A lot of reassurance, a lot of time spent on consultation, finally kept them at ease, and with a happy heart, they left my clinic. Obviously, the treatment part was secondary, but here counseling, reassurance are very, very important for psoriasis. Now, let us define psoriasis. Let me tell you, when you study a disease, there are some points which you need to look into while trying to discuss a disease. Right also, if you're trying to write a short note on a particular disease, a definition, its epidemiology, a brief touch-up on pathogenesis, then the clinical features, then the differential diagnosis, treatment, and prognosis. These are the some points, salient points, which you need to touch upon when you're writing a short note or even a long question on a particular disease process. Bare mugging up will not help you. You may miss out some points, right? So let us define psoriasis first. It's a non-infectious, chronic inflammatory disease of skin with a polygenic predisposition. And what is it characterized by? Well-defined, look into it, well-defined erythematous, that is red, plaques. Plaques are larger papules, larger in size, with silvery scale, as very effectively summarized by the famous writer John Updike. Silvery, or also called micaceous scales, and a chronic fluctuating course. Obhrer moto scale amra bole thaki, right? And this is a chronic disease. Thakbe, it will not leave you as such, right? We are looking at a lot of chronic diseases now. Presently, diabetes is a chronic disease, it will not leave you. Hypertension is also a chronic disease. So when patients initially come to us and ask us, doctor, will I not be cured of psoriasis? Fortunately or unfortunately, we have to tell them, look, this is a chronic inflammatory disease. Eta apnar songe thakbe. It can be controlled. Bhalo thakben. Kintu cure ma nirmul hobe na. So this is very important. You have to keep in mind adequate counseling the patient right at the first visit will lay to rest a lot of fears in their minds. Okay, so allaying the fear and anxiety of the patient is very important in this condition. So As I said, from definition, we move to epidemiology of the disease. Psoriasis has two different ages of onset. One is early in teenage and early adults, which is a more severe and persistent form seen in them with a positive family history, as I had already mentioned, polygenic predisposition, and a late onset is between 50s and 60s, right? Incidence is between 1.5 to 3% of the population, which equals sexual incidence in both males and females. And as I mentioned, polygenic with an HLA-CW6, right? Incidence of HLA-CW6 involvement in psoriasis is very important. Moving on to the trigger factors. What particular factors trigger an episode of psoriasis, right? Physical trauma is very important. Here we have a term called Koebner phenomena. If you can remember, you can write in your short note or in your theory paper, if by chance your internal or external practical examiner has had an exposure of dermatology in his or her clinical early years, post-medicine. So definitely, if they have it Koebner in their mind, they can definitely ask you, what is it, a Koebner phenomenon? Basically, this is an isotopic phenomena where a minor trauma, such as scratching or any other trauma, etc., can see to replication of active psoriatic lesions at the site of trauma, right? So this is an injury, be it a minor in the form of an abrasion or a major injury, could lead to reciprocation of the lesions or development of psoriatic lesions at the site of trauma. So this is a very important trigger factor, and this proves that psoriasis is unstable. Then infections, especially in children, beta hemolytic streptococcal throat infections can precipitate the gutted variety of psoriasis. I'll show you what are the varieties of psoriasis and try to show you some slides also, the photographs. Stress, this is a very important cause of flare in 40% of cases. Maybe that young married lady, the stress of marriage had led to flare up of psoriasis, which had gone undetected previously. Also, very recently, today evening, I also have similar patient. I saw a case of chronic psoriasis, plaque psoriasis, which I have been seeing this 70-year-old gentleman for more than 1 decade, right? 10 years plus. Suddenly, he had come today again for consultation after 3 months, basically in this COVID flare-up, showing flare-up of psoriasis. So stress is a very important cause of flare-up, and some drugs like antimalarials, lithium, and amongst the psychotropic drugs, beta blockers, systemic steroids. Look, this is very important. Maybe you all will not be dermatologists in future. 1, 2, maybe you will not be able to diagnose a lot of skin diseases, but it's a request. Without confirming the diagnosis, please do not prescribe systemic steroids in the patients with dermatological disorders, because psoriasis is a very common disorder where if you suddenly prescribe systemic steroids and withdraw them, maybe initially you may give relief to the patient, but subsequently it will severely flare up, and we, the dermatologists, will have a lot of headache trying to control this flare up of psoriasis. Okay, so these are the 4 principal trigger factors: physical trauma, infection, stress, and drugs. Let me off the record just tell you what I am speaking, or I'll be speaking over the next 40-45 minutes, are all in your standard undergraduate textbooks or medicine which you read up. Very little information I have provided from postgraduate dermatology textbooks. So you can look into this. If you remember this presentation, I think a 5 or a 10 mark short note on the Papulo squamous disorders would be just a simple cup of tea for you. Well, now moving to etiology. This is in a nutshell. Etiology of psoriasis is pretty complex. That is why the treatment, a lot of cytokines are involved. Molecular biology has forayed into the etiopathogenesis of psoriasis. Basically, cell kinetics of keratinocytes have changed in psoriasis. The normal epidermal cell turnover in psoriasis is shortened to 11 hours from a normal 311 hours. So the cells are rapidly turning over, and with the formation of scales and from the stratum corneum, they are being shed. This is basically, again, a T lymphocyte driven disorder with a lot of cytokines like interleukin 1, 2, 8, and a lot of other pro-inflammatory cytokines are responsible for initiation and maintenance of lesions. So all this etiopathogenesis does have a good value when you are thinking of treating or managing a case of psoriasis, especially in systemic therapy. A lot of systemic therapies aim at reducing the level of these interleukins and cytokines. Presently, even biologics have come up in the treatment of psoriasis, which are based on inhibiting these upregulated cytokines. Okay, this is in a nutshell about the etiology of psoriasis. Moving to histopathology. Skin biopsy in some difficult cases where all the clinical pointers or clues are not fitting into, as I said, the jigsaw puzzle. You are maybe thinking of a psoriasiform disorder or a psoriasis-like dermatosis. You can clinically not properly confidently say that you are looking at a case of psoriasis. There, you need the help of a skin biopsy. A 4 mm or a 5 mm punch skin biopsy will help you to seal the diagnosis. What are the classical histological features? Well, from the epidermis, we'll have acanthosis, thickening of the epidermal layers, parakeratosis. Parakeratosis, in a nutshell, is finding nucleated cells, nucleated keratinocytes in the stratum corneum. Stratum corneum, if you remember, is the outermost layer of the skin where you do not have nucleated cells. But here in parakeratosis, you'll have nucleated cells out there. Microabscesses, these also neutrophils and may conglomerate in the upper layers of the epidermis. Capillaries may be dilated and tortuous, surrounded by a mixed neutrophilic and a lymphohistiocytic. So both lymphocytes and histiocytes may be present surrounding the vasculature. If you can remember these histopathological pointers, okay, you write down. If you don't, better skip it, right? Because you need to be properly exposed, see the slide under the microscope to come to a confirmatory diagnosis. Moving on to the clinical classification of psoriasis. The principal clinical types of psoriasis are now psoriasis vulgaris. What does the word vulgaris mean? The word vulgaris in Latin means common, right? Chadarum. Acne vulgaris. Lupus vulgaris. Skin tuberculosis. The word vulgaris means common. Psoriasis vulgaris. Chronic. Amongst psoriasis vulgaris, the common types, acute guttate psoriasis is seen in children, basically following a beta hemolytic streptococcal infection I've already mentioned. Then we have chronic plaque psoriasis. Chronic stable plaque psoriasis is most important to people who suffer for a long time. Chronic plaque psoriasis, stable. Some cases, when flares-up occur, we can say unstable variety. Palmoplantar psoriasis, restricted only to the palms and soles, and inverse or flexural psoriasis. While I'll describe the classical psoriatic lesion, I will mention, if you remember, while I was giving the definition, what I said, well-defined erythematous patch with silvery white scales. Another important point here is an extensor distribution, right? It prefers the extensor extremities more than the flexural one. While I'll be subsequently discussing lichen planus following psoriasis, lichen planus, however, has a tendency for a flexural predilection rather than an extensor predilection. So this variety of psoriasis, the inverse or the flexural one, is the name suggests, is inverse or opposite to the normal chronic stable plaque type. Then we move on to psoriatic erythroderma. The word erythroderma in dermatology means reddened skin in where the lesions have involved more than 90% of the body surface area. So you see, psoriasis may be such a disease, such a disfiguring disease with tremendous psychological impact where it can involve even more than 90% of the body surface area. These patients are preferably to be admitted in dermatology wards and treated so that the disease can be controlled and then discharged. And another serious variant of psoriasis is pustular psoriasis. Again, very difficult to control. Systemic medications, long-term treatment is very important. Here, pustules take predominance. So, psoriasis vulgaris with its 4 principal types, guttate, the commonest chronic stable, palmoplantar, inverse or flexural. Moving on to psoriatic erythroderma and pustular psoriasis. Shomo, am I going too fast? Am I going too fast?
No, it's okay.
Okay, fine.
Okay, sir, it's okay.
Okay, fine. Next, we move on to the clinical features of psoriasis. Pruritus, is reasonably common. Look at the term reasonably common. Why reasonably? Some patients do complain that they do not have pruritus or don't mention it. And others say it is definitely pruritic. However, when we'll be discussing lichen planus, we'll distinguish between the two in that lichen planus is severely pruritic, common comparing to psoriasis. Now to acute guttate psoriasis. This is most commonly seen in children and adolescents. As I have mentioned, may follow a streptococcal sore throat. In Latin, gutta means drop. That is like raindrop-like lesions on the trunk, front or back. What will you see? Sudden onset, acute as mentioned, with salmon pink papules. Again, in an Indian skin, this is a Westerner skin. In Indian skin type 4, 5, we cannot properly appreciate the salmon pink color. They may have or may not have scales. As I already mentioned, this is more seen on the trunk, and usually acute guttate psoriasis resolves spontaneously within weeks or may sometimes evolve into the chronic stable type. Chronic stable psoriasis, most common variant, as I already mentioned. Don't worry, I'll be showing you clinical photographs also. First, let me discuss the basic points, and diagnostic points. Then while I'll show you clinical photographs, I'll equate with what I have discussed with you in the clinical pointers. This is the most common type. Initial, when I defined, I said well-defined, again, similar, sharply marginated, dull red plaques with silvery white, loosely adherent scales. Why loosely adherent? You can remove the scales if you want, right? The very next point says, this is again a very good clinical pointer to diagnose a case of psoriasis. If you remove the scales of psoriasis, don't try to remove with your nails. You'll hurt yourself, maybe get some infection, or you'll hurt the patient also. Don't try to remove the scales with the nib of a pen, ballpoint pen, or whatever be it. There's a typical technique of removing the scales. You can take the end of a glass slide and slowly remove it without hurting the patient. What will you see? Appearance of minute bleeding points. This is called auspice sign, a very important clinical diagnostic criteria for psoriasis. Why the minute bleeding points? If you go back and remember the slide which I discussed about histopathology of psoriasis, I had said there would be dilated capillaries. The papillary dermis will have dilated capillaries. And while removing the scales, you may nip open the tip of the dilated capillaries. So minute bleeding points can develop. As I already mentioned, it has a predominance for the extensor surfaces, the knees, the elbows, amongst other sides, scalp, palms and soles. I mentioned palmoplantar psoriasis, lower back, very important site. You mandatory to examine the patient, examine the scalp, examine the palms, examine the soles, examine the knees, the elbows, the lower back. This is usually symmetric and bilateral, right? So this is chronic plaque psoriasis, well marginated, dull red scales I mentioned, dull red plaques I mentioned, erythematous plaques with silvery white or micaceous scales. Removal of the scales may show auspice sign, classical sites of predilection, bilateral, often symmetric. As I show you some photographs, you'll try to write. This is a classical, I think you can well appreciate the typical plaque, dull red, well marginated, whatever points you see the photograph. Is the slide clearly visible, the photo? Everyone can see the slide clearly?
Yes, sir.
Right. Okay, you can appreciate it. As I mentioned, the classical silvery white scales are seen, the well marginated dull red plaque is seen, and the site of predilection is for you to see and properly fit in the, again, pieces of the jigsaw puzzle to come to a diagnosis. Right. 4 different sites. Top left, you are seeing lakes of pus, right? This is a pustular variant of psoriasis, as I mentioned. Right top, this is plantar psoriasis. Here, scales are there, the thickened part of the skin, you can still the margination is visible. Then lower right, you are seeing a typical case of scalp psoriasis, right? The erythema is visible, the scales are also seen, and this is quite irritable for the patient. And the lower left, these are the nail changes seen in psoriasis, not clearly visible, but I'll discuss the nail changes. So, in a case of psoriasis, You need not look at the skin also. You have to look at the scalp. You have to look at the nails also. Your examination, dermatological examination, is incomplete unless you examine the hairs, nails, and the mucosa, the oral mucosa and the gentle mucosa too. This is what we teach our postgraduate students. For you, UG people, well, you examine the skin, and if you have seen the nails, you have read it up, you have find any typical distinctive diagnostic feature in the nails, definitely, if you are confident enough and read it up, please do mention it to the examiner that I have seen this nail change. আমি এটা নোকে দেখেছি স্যার, এইটার সঙ্গে এই ক্লিনিক্যাল পার্টগুলো পাওয়া গেছে। So all these pointers will fit in together to help you to come to a diagnosis, right? Now let inverse psoriasis, as I mentioned, this occurs in later life. Again, these are well demarcated plaques. However, here the involvement is in the flexural areas, the cleft, খাঁজগুলোকে দেখতে হবে, right? Anal cleft, the groin, submammary areas, and the distinctive, another important feature is in inverse psoriasis, scaling is rare. Now, psoriatic erythroderma. As I again mentioned, this involves greater than 90% of the body surface area. Skin is red and scaly, right? The patient may have constitutional symptoms. Excessive loss of scales may lead to patients losing proteins, electrolytes. Their patient may have hypo or hypothermia. The patient may fever, malaise, everything. So dermatology along with constitutional symptoms together will be grouped under psoriatic erythroderma. And pustular psoriasis, I showed you the slide. It can be localized involving the palms and soles, or the generalized variety that is called the von Zamruth's variety. However, you cannot culture an organism from these pustules. These are sterile pustules on a red base, and the patient may be toxic, requiring admission, requiring, I also already mentioned, requiring systemic therapy. Associated features, nail changes. In up to 50% of cases, you can see nail changes. That photograph, it's very difficult to appreciate that photographs in a Zoom meeting, the nail changes, but nail pitting was there in that photograph. Okay, this is called thimble pitting. Subungual hyperkeratosis may be present. Below the nail plate, you can find thickened skin. Onycholysis. What is onycholysis? The distal part of the nail plate may be separated from the nail blade. নোকের মাথাটা যেন মনে হচ্ছে উঠে গেছে, ফাঁকা হয়ে গেছে নোক থেকে। পেশেন্টরা মাঝে মধ্যেই কমপ্লেন করে, ডাক্তারবাবু নোকটা যেন খসে বেরিয়ে চলে আসছে। And another important criteria is yellow brown discoloration of the nail plate. Yellow brown discoloration of the nail plate is also an important criteria. Another important associated feature in case of psoriasis is arthropathy. Though seronegative, it can develop in 5 to 10% of cases. It has 5 different clinical patterns. We'll not discuss the different clinical patterns. If you have time, you can read up from standard textbooks, but it can be pretty debilitating also. It can only inform the phalanges, or it can be widespread, involving the entire limbs also and the spine too. Now, as I mentioned, we have touched upon the etiopathogenesis. We have briefly described the histopathological features. We have discussed the clinical classification, the salient clinical pointers to diagnose the various types. Now we move on to differential diagnosis, right? Differential diagnosis, prognosis, and treatment. These are the 3 areas where we are still left with. Now, for acute guttate variety of psoriasis, drug eruption. Look, this is a very important, let me give you a tip. A lot of dermatological disorders, especially the acute ones, can be mimicked by various drug eruptions. We call it adverse cutaneous drug reactions, or ACDR, which can be benign, or some may be even severe. So drug eruptions you can jolly well put in as a differential diagnosis. If you cannot write acute guttate with drug eruptions, syphilis is an important infective differential diagnosis for guttate. Pityriasis Rosea, I'll show you slides of Pityriasis Rosea. Plaque psoriasis, seborrheic dermatitis, some annular lesions may mimic tinea. For inverse psoriasis, again, this is involving the clefts. So candidiasis would come in, intertrigo would come in, and again tinea would come in. Kichu na mone thakle eram alada alada kore, at least tinea seborrheic dermatitis, Pityriasis Rosea, drug eruption লিখে দিলেও চলবে, কেউ কিন্তু নম্বর খুব একটা কাটতে পারবে না। আলাদা করে যদি এরকম acute guttate plaque on inverse psoriasis, if you do not remember, cannot write. Okay, now we want to cause and prognosis. As I already mentioned in my first slide when I was defining the disease, that it is chronic and recurrent. Patient কে প্রথম দিনই কাউন্সেলিং করতে হবে, যে প্রেসার সুগারের রোগ যেমন নিয়ম মেনে চলতে হবে, ভালোভাবে থাকতে হবে, খেয়াল রাখতে হবে, ডায়েট সবকিছু, তবে কমবে, কন্ট্রোলে থাকবে। Same with here with psoriasis. It's a chronic condition. There may be flare-ups, chronic and recurrent, and it can be a lifelong companion. Let me share a story. In the trigger factors, I did not mention two trigger factors. Well, alcoholism and smoking are two trigger factors which can lead to recurrence or exacerbation of psoriasis. আমি আমার clinical career থেকে আবার I would like to share a small story with you. A long time back, more than 10-12 years, I had a middle-aged gentleman, very fair, good-looking, marginally obese, who used to visit my clinic. At least he came twice to my clinic. He used to get down in front of the clinic from a big mid-segment car, and then he used to wear a Punjabi and a pajama and reach my clinic. Ultimately, he had chronic plaque psoriasis affecting more than 20% of the body surface area. Okay, chikitsa kollam 2-3 bar. Casually, when I was asking him about his addiction, he's a chronic alcoholic for a long time. So then I requested him, you have to cut it down, you have to be on the, at least be disciplined with regard to this, otherwise it would be very difficult for me to control the disease. Strangely, you won't believe, I would not advise you with this, but this has a element of humor in it. The patient ultimately 2 সপ্তাহ পরে আমাকে বললেন, ডাক্তারবাবু আমি আর দেখাবো না। I was a bit surprised. I asked him, কি হলো? Quite senior to me. Then I was in my younger days, so at least 10-15 years senior to me. I asked him, what's your problem? Why don't you want to persist? He was financially very well off as per his looks, and he used to come, get down from a big car and enter the clinic. So I asked him, what's the problem? He said, doctor, you have told me to cut down on my alcoholism. That is impossible for me. I would better live with psoriasis than cut down on my alcoholism. So these things are also there. Just in a lighter way, sharing a joke with you. This is very important again, that you cut down on those habits to keep your psoriasis under control. Now, treatment, I haven't discussed your treatment, just I will mention it. There are 2 major forms of treatment, other than educating and counseling the patient. One is topical treatment, where you apply creams to the skin. If it involves less than 10% of body surface area, then you apply topical ointments to the psoriatic plaques. That would include topical corticosteroids, mid potency in groin folds, etc. Lower potency, topical corticosteroids in BD dosage, or in some case mid-potent steroids in OD dosage till they are controlled, or the lesions, gradually the erythema fades, the pruritus, if at all is present, decreases, and the scaling also comes to a rest. And along with it, you have moisturizers or emollients, which have also been used significantly so that the patient feels comfortable and the scaling, the excessive proliferating scales can be controlled. So topical corticosteroids and emollients or moisturizers are the gold standard of topical treatment for psoriasis. The various other topicals which are available are, you will read in your standard textbooks. If you read Kumar and Clark, Davidson or whatever, forget the bigger medicine textbooks, you'll find it is mentioned there. Topical tar therapy is mentioned. Short contact therapy of diethranol is mentioned. 20 to 30 minutes twice daily over the plaques and then wash off. Then vitamin D analogs are also mentioned. Calcipotriol, calcitriol, all these are topical therapies in case of psoriasis. Now, if it involves more than 10% of body surface area, that is, if it's moderate to severe psoriasis, you need to go in for systemic medications. Amongst the systemic medications, again, a big no-no to systemic steroids. You do not use systemic steroids in psoriasis except in 1 or 2 rare cases, which is beyond the purview of discussion with you, because you'll be appearing in an UG examination, not a PG examination. Okay, for the systemic drugs, the therapeutic arsenal includes methotrexate, right? After proper biochemical protection, looking at the hepatic profile, looking at the hematological profile, you can very set drug, you can continue for months together to control. Then we have oral retinoids, acitretin, another very important drug. Pregnancy is the notable contraindication where you do not use it. Okay. And now presently, I'm just touching upon the names. Now presently, we have biologics, injectables, a lot of them, various interleukin 12, interleukin 23, tumor necrosis factor alpha inhibitors, which if you just have the time, you can read the names and mention them in brief in your answer to the question. Okay, so that brings us to the end of the discussion on psoriasis. Now we'll move on to our next papillosquamous disorder, that is lichen planus. I was trying to equate some of the presenting features of psoriasis with lichen planus. So let's again start with defining lichen planus. Lichen planus is a chronic pruritic. Again, just look into it. I'm starting the definition with the word pruritic. You are diagnosing a case of lichen planus, yet the patient in front of the examiner, when the examiner asks, chulkai, the patient bluntly and bluntly says, nah, doctor, chulkai na, then it's better you have to be skeptical with your diagnosis and retrace your steps and think of some other diagnosis. Okay, so it has got to be pruritic in majority of the cases. Then we have, it's an inflammatory dermatosis involving here the skin and the mucous membrane. The definition brings in the mucous membrane here, which we did not mention in psoriasis. Okay, while I was telling you in general examination of dermatology, you have to look into the skin, the mucosa, the hair and the nails. In psoriasis, there was no significant mucous membrane manifestation, so I did not mention it. Here, lichen planus is notorious if mucosal lichen planus, especially I'll show you photographs of oral mucosa or the genital mucosa, very, very difficult to treat. It persists for years together, let me tell you. Again, here, age of onset, we have a single age of onset, 30 to 60 years, quite a long range. Though in pediatric age group, you can also see lichen planus cases. Here we have a slightly more female predilection than males. And in etiology, basically it's an idiopathic, right? Here we are telling idiopathic, please note. Again, here also CMI plays an important role with not only CD8 cells, memory cells are also involved. Some drugs like gold, mercury, sulfonamides, thiazides can cause similar type of rash like lichen planus, which we call lichenoid drug reactions. Okay. Hepatitis B, C, chronic active hepatitis, you have to, if you are diagnosing a case of lichen planus, you take history whether the patient has hepatitis B, C or chronic active hepatitis. Basically, etiology, if you are asked one word, idiopathic, right? And if you want to elaborate on it, you can elaborate, right? These hepatic infections could lead to precipitation of lichen planus. Some drugs could lead to precipitation of lichen planus. Okay. Moving on to again, histopathology. Hyperkeratosis. There I mentioned, if you remember in psoriasis, acanthosis and parakeratosis, here hyperkeratosis, hypergranulosis. The granular layer just below the stratum corneum is thickened. Normally it is 1 to 2 layers, it is more. There may be basal cell degenerations. So if you remember the layers of the epidermis, stratum corneum, stratum granulosum, stratum malpighi, and stratum basale, the bottom layer, just bordering the dermis. Here the basal layer may be degenerated with colloid bodies and T lymphocytes in the upper dermis. If the basal layer breaks down, then some keratinocyte, etc., may fall down into the upper dermis, while so we are seeing colloid bodies and some lymphocytes may also come down from the epidermis to the upper dermis. Now moving on to the clinical features. Onset, here it may be acute or insidious. A variety of lichen planus is seen, which is called eruptive variety, which in a very short period of time you may find lot of lesions developing in the patient. As I mentioned in the definition of lichen planus, you see pruritus is a double plus, and mucous membrane lesions. Again, I am picking out the USP of lichen planus, which differentiates it from psoriasis. The mucous membrane lesions would be painful when ulcerated. I will tell you the oral mucosa, the lips, the buccal mucosa, the lips, the genital, penis, and also and the vulva, you may have lichen planus like lesions, and they are very difficult to control. The classical clinical appearance of a case of lichen planus. Well, we remember this. I'll show you subsequently slides and photographs. We remember this by 5P and 1S, a dictum. What are the 5 P's? One is papule. Flat topped, you can call it planar. So papular, planar, plain or flat topped. Polygonal, purplish, pruritic. Okay, purplish or violaceous. Here we see violaceous, sometimes we see blackish also in Indian patients. So papular, if you do not remember anything, only if you can remember 5P and S, you can at least write 2 to 3 points in your clinical features of lichen planus. So papules are the principal lesions here. They may be flat topped or planar. The top of the papules being plain. They may also be polygonal in shape. They are purple in color, violaceous and pruritic, as I mentioned in the definition. Those are the 5 P's, and a single S is Wickham's striae. If you can remember it, what basically is Wickham's striae? On the top of the lesions or the surface of the lesions, you will find fine lacy white patterns. Cause of Wickham's striae, you need not know, at least at present. Later on, you can read up. If you are interested in dermatology and you try to correlate the points, you can find out the cause of Wickham's striae. That is written in standard textbooks. Now, how do they look like? They may be scattered, discrete. The lesions, papules may be in groups. They may be annular. Annular lichen planus may be patient on the face. They may be present on the penis, and they may be disseminated too. Okay, especially when they're generalized. As I was mentioning, the eruptive variety of lichen planus can present like this. And in dark-skinned individuals like us, incidence of post-inflammatory hyperpigmentation is very important. What is post-inflammatory hyperpigmentation? Any inflammatory lesion. As I defined lichen planus, I told you it's an inflammatory lesion. Any inflammatory lesion, when it subsides, it leaves behind a hyperpigmented area, be it a patch, right, or a plaque. And this post-inflammatory hyperpigmentation is very difficult to remove. Basically, we don't focus our treatment modalities on removing the hyperpigmentation. It gradually subsides over time, and that may be several years also. তাহলে পেশেন্টরা মাঝে মধ্যেই আমাদের কাছে বলে যে ডাক্তারবাবু চুলকানিটা কমে গেছে আফটার সে ফিউ মান্থস অফ ট্রিটমেন্ট, উঁচু উঁচু যে লিশনগুলো ছিল, দানাগুলো ছিল প্যাপিউল, সেগুলো প্লেন হয়ে গেছে, কিন্তু কালো দাগটা যাচ্ছে না। It is very difficult right at your first time consultation when you are discussing the disease in brief with the patient. You definitely have got to mention that post-inflammatory hyperpigmentation is a chronic headache, and do not worry about it. Gradually it will leave. And again, like psoriasis, Cobnus phenomena is also present in lichen planus. Okay, so 2 diseases we have learned which have Cobnus phenomena. This may help you in your future postgraduate entrance MCQs also, right? So what are the sites? Initially I was comparing with psoriasis. I had mentioned it's a predilection for the flexors, though it can be generalized too. So flexor wrist, the lumbars, the shin, the scalp, typical variant focus. Penis I already mentioned, oral lesions I said. Here, nail change is pterygium. Pterygium, like say in ophthalmology, you had seen pterygium wing-like. Nail plate may show wing-like disposition. I had a photograph of it, but I didn't put it in because maybe I don't want you to focus too much on this abnormal ectopic variants rather than forget the basic things. So I didn't show the photograph of pterygium. And nail may have dystrophic changes. Dystrophy basically means nail is getting destroyed. Okay. Again, like psoriasis, what are the clinical variants of lichen planus? We can have hypertrophic lichen planus, which is raised, thickened plaques, hyperkeratotic. Usually shins are a location for it, and it's very, very difficult to control. It may take several years to control hypertrophic lichen planus. So this is very important. Then we have atrophic. Right at the other part of the story is atrophic lichen planus. Okay, follicular lichen planus, scalp lichen planus lesions may involve or surround the hair follicles. It is called follicular lichen planus. Vesicular bullous lichen planus may be there. Fluid filled lesions, smaller in size are vesicles and larger in size are bullae. Okay, they may be vesicular bullous, though these are rare. Lichen planus may have pigmentary variant, pigmentosus. This is again, if you can remember the names, you can write in your answer scripts, but if you venture into dermatology in future, these will be things which will appear very interesting for you. Actinic lichen planus, as the name suggests, sun exposure is an important factor. Obviously, in exposed sites, the face, and an ulcerative variant can also occur. Okay, so these are the principal variants of lichen planus. Moving on to differential diagnosis, as I mentioned, psoriasis, we are discussing Papulo squamous disorders. So if you can remember the names of Papulo squamous disorders, you can fit in any Papulo squamous disorder as a differential diagnosis of the other diseases. Okay, for psoriasis, if you want, you can put in lichen planus. So usually lichen planus is rare disease, but eczemas can also come into differential. Pityriasis Rosea, I'll be discussing subsequently. Pityriasis Rosea, drug eruptions, as I said, they fit into it, lichenoid drug eruptions. So before now treatment part, lichen planus, again, topicals and systemic medications. For topicals, topical corticosteroids, because it is an inflammatory pathology, so an anti-inflammatory topical preparation. Topical steroids are again the gold standard of the need of the hour. Topicals can be used in restrictive areas. If, say, it is eruptive, involved, generalized, even here you can go for systemic steroids for their immunosuppressive role. Okay, so topical corticosteroids, extremely pruritic, so obviously antihistaminic, antipruritigenic agents have to be given, and for a long time. Okay, you have to safely use antihistaminic, topical corticosteroids, and for systemic medication, you can use oral corticosteroids to control the flare-up and then gradually taper off and move on to topical corticosteroids for follow-up or maintenance. And even some other immunosuppressives like systemic methotrexate, azathioprine, these can also be given in severe cases of lichen planus. If you remember, you write. So just I'll give you the tip while writing treatment. The saline tip here, treatment, you give 2 arrows, algorithm like topical, write down 2 to 3 names, if possible BD, write down, and duration till control. If you cannot remember how long to use, just till the lesions are controlled, you can put in. And systemic, write down the names possible. If you can remember the doses, duration, 1 to 2 lines. If cannot, at least the names will be sufficient for a 5-mark short note, because you are covering all the other points here. Okay, that puts in treatment part. Now, course and prognosis. Cutaneous lesions may persist for months to years. Please note, from months to years. As I already mentioned, oral lichen planus, hypertrophic lesions can even go decades, and you have to spend significant amount of time in your earlier consultations with the patients or the patient's relative, properly educating them, sir or madam, this is a slow process, be patient, don't be impatient. If you are patiently taking the medications, definitely the disease will gradually come into control and this can be cured. This is the last important in prognosis, the ulcerative oral lesions. Why I was stressing on oral lichen planus? 5%, some studies, higher incidence, oral squamous cell CA, usually 1 to 2% is more than enough, the incidence of ulcerative oral lesions turning into malignancy. So oral lichen planus, be very careful in future. Okay, treatment long-term, continue with topicals, and patients, again, any addiction, etc., which are focusing factors, has to be removed from the daily diet workout. Some photographs of lichen planus. The top left, again, this is a hypertrophic variety of lichen planus. You can find the raised, blackish violaceous color in Indian screen or purplish is difficult to appreciate, blackish part. Again, the lower left, if you again focus on it, you will find a blackish plaques on the extensor here. The lower right, this is typical flexor lesions. These you can appreciate the papules, the flat topped, as I mentioned, the grouped flat top papular lesions. Here the color hasn't reached that blackish hue yet. This is slightly on the dull erythematous side. Multiple lesions are also visible, and the upper right, you can typically appreciate in the buccal mucosa the lacy. There are four at least variants of oral lichen planus. Here you can typically appreciate the lace-like network of oral lichen planus. Okay, And this is, mind you, a chronic headache for us dermatologists to treat oral lichen planus. A lot of the ENT specialists also see, the dental people also see and diagnose and even treat oral lichen planus. But ultimately, it comes down to or boils down to us to give the chronicity, to explain the chronicity of the condition and to continue and keep the patient in line for long-term treatment. Okay, so these are the 4 slides: hypertrophic variant, the normal variant, and the oral lichen planus. Okay. Again, the lip, the violaceous hue, I think is appreciable on the lower lip. This is classical lichen planus of involving the lower lip. And here again, the left hand side, the photograph on the dorsum of the hand, you can appreciate this plaque, the typical blackish color, and some smaller papular lesions also adjacent to the bigger plaque there on the dorsum of the hand. These are extremely pruritic. So these are some slides of lichen planus. Treatment, as I already mentioned, topical corticosteroid, oral steroids, retinoids, even oral antihistaminics. So I've discussed this treatment part. Okay. Now moving on to our third and last papillosquamous disorder, which we'll be discussing today, that is Pityriasis Rosea. Let us define Pityriasis Rosea. This is again an acute condition, right? Exanthematous eruption, right? With a distinctive morphology. Whom is it seen more? In adolescent and young adults. And this has a self-limiting course. This is very important. It has a self-limiting course. As we compare with psoriasis and lichen planus was in years and decades. Psoriasis, lifelong companion. Here, at least your patient should be happy, and you should be happy because this is having a self-limiting course with a seasonal predilection in spring or in autumn. Classically, a disease of the fall, if you appreciate or if you want to speak in Western terms, spring and autumn. Hemonte or Boshante beshi dekha jay. Keno? Etiology not very clear. Probably viral etiology, human herpes virus 6 or 7. That's it. Because probably viral etiology, some people do advocate using oral antivirals for treating this condition, though it will be self-limited. What are the clinical features? Pruritus may be absent or mild. So if you compare the 3 diseases, one pruritus psoriasis was relatively common. Lichen planus pruritus double plus or triple plus has to be present. Here on the other side of other pole, right? Pruritus may be mild or absent. What are the classical clinical lesions of Pityriasis Rosea? Herald patch. This is most important. In 80% of cases, I'll show you a photograph of the herald patch. This is oval, slightly raised. Oval, slightly raised, can be a patch or a plaque, 2 to 5 centimeters. That are flat with the surface, that is a patch. That are raised from the surface, that's a plaque. Salmon red, our salmon red, Bideshida description, our khetre, reddish or slightly dull reddish, with most important is fine colored scale. Oval plaque at its side can demonstrate fine scale. This is called correlate scale. Exanthematous lesions may also be present. That is, scaling papules may be present, plaques may be present, dull pink in color. They may be scattered along the long axis of dermatological lines. The skin lines gulo ba dermatological lines se long axis e distributed hote pare, take bola hoy Christmas tree pattern of distribution. Christmas tree বা ফিগ ট্রির কথা যদি মনে থাকে, এখন তো আমরা আজকাল বাঙালিরা ক্রিসমাসও ছোট বাড়িতে নিজেদের ছোট ছোট ক্রিসমাস ট্রি লাগাবার চেষ্টা করি বাচ্চাদের আনন্দ দেওয়ার জন্য বড়দের। তো যদি চোখ বুঝে যদি একটু ক্রিসমাস ট্রিটার সম্বন্ধে একটু নিজের মাথায় ভাসিয়ে নেওয়া যায় ছবিটা, তাহলে টিপিক্যাল যেরকম হয়, ক্রিসমাস ট্রি প্যাটার্ন ইজ লাইক দ্যাট। I'll show you the photograph in the subsequent slide. Okay. খুব সুন্দর herald patch, classical herald patch. I think you can appreciate the oval lesion and slight scales surrounding the periphery of the lesion. এই স্কেলটাকেই বলে ফাইন colored scale. Psoriasis scale micaceous, silvery white, loosely arrayed, অভ্রের মতো। এটা কিন্তু হালকা দাগ জুড়ে স্কেল, ওকে, ফাইন colored scale. Surrounding it, you are seeing some papular, slightly erythematous lesions also visible. Christmas tree pattern মতোটা দেখা যাচ্ছে? কিছুটা ইমাজিন করতে হবে ক্লাসিকে you cannot draw a Christmas tree on the back of the patient skin and say this is the typical Christmas tree. That is not possible, but it looks like the distribution of the lesions look like a Christmas tree pattern. Okay, so what I just now taught you, herald patch and Christmas tree distribution pattern on the trunk. Okay, this is visible now. Again, this child, you can see a lot of lesions distributed. The herald patch is not visible, but it is exanthematous type lesion, right? Viral exanthem jamoy, papular lesions, multiple trunk distributed. Kichuta dermatological line jule kichu kichu royeche, especially on the left side. You can appreciate that. Okay. So what are the sites? Photographs are in self-explanatory. ছবিগুলো মনে রাখতে পারলেই কিন্তু অনেকটাই কাজ হয়ে যাবে, কিছু মনে না রাখলে। Trunk, proximal arms, legs, rarely face. Again, differential diagnosis. The common shock. Guttate psoriasis, I had put in Pityriasis Rosea. Drug rash fits into everything. Tinea. For psoriasis also, you can put in tinea. Again, for Pityriasis Rosea, you can put in tinea. And secondary syphilis comes in. Once upon a time, when in our younger days, it was said that you know syphilis, you know medicine, because it would influence all the systems. Presently, we talk similarly in lines of HIV infection. Okay. Course, spontaneous remission. Agei bolechi, self-limiting, 2 to 3 months, 6 to 12 weeks, usually. Atypical Pityriasis Rosea ache, Pityriasis Rosea classical variant I discussed. For us dermatologists, for dermatology PG students, a lot of variants of Pityriasis Rosea you also have to keep in mind. Even drug-induced Pityriasis Rosea also you have to keep in mind. For UG, you do not need this. Arekta importance ki, recurrences are common. প্রতি বছরেই হেমন্ত আর বসন্ত আসবে, ভাইরাল ইনফেকশন হতে পারে, ফলে Pityriasis Rosea can come back and haunt you for some time. Okay, self-limiting, again that is a plus for you. Treatment কি? Pruritus থাকলে oral antihistaminic, topical antipruritic lotions, low potency topical corticosteroids, self-limiting, patients symptomatic improvement, low potency topical corticosteroids will be sufficient. Phototherapy, psoriasis phototherapy was important. Ekhaneo phototherapy important. Treatment of basically phototherapy in 1 hour, it's very difficult to discuss the element part of phototherapy. So just knowing it, if in later classes, so this is not required in your UG curriculum. That's why you would better avoid it. So that puts us to the end of our discussion on Papulo squamous disorders. Thank you, students, for giving me a patient hearing. Thank you. So 1 hour complete হয়েছে তো? ডক্টর জান ওকে?
হ্যাঁ, ঠিক আছে স্যার। 1 hour এর মধ্যেই হয়েছে। Thanks a lot, very nice presentation. আমরা সারাক্ষণ শুনছিলাম। So I would request the students to to go for any queries if they want to ask, and send it to sir via chat. You just chat all the queries, and so that there can be a two-way discussion. That's my request to students. If there is any query on part of you,
কোয়েরি থাকলে চ্যাটে করুন। তাও যদি দেখো সমর যদি পরেও মনে করে কোয়েরি করবে, আমার ইমেল আইডি দিয়ে দিও, আমাকে কোয়েরি করতে পারে, আইল ডিসকাস।
ডেফিনেটলি।
যদি তৃষানো যদি মনে করে আমাকে কোয়েরি পাঠাতে পারে, আই ক্যান ডিসকাস, নো ইস্যুস।
So any queries from the students for the coming 2 minutes? We will wait for any queries which come to the inbox or coming to the query in the chat box, so that we can
have I bombarded them with too much information?
No, it's okay, sir, because the informations which we have shared, there is psoriasis presentation was very good, and apart from that,
already a first question from Vishari. What is the difference between true and reverse Koebner phenomena as psoriasis shows in both types?
You do not need it now. There is a classical difference, pseudo Koebner, reverse. True Koebner phenomena itself is a short note in our postgraduate year and curriculum. So I don't think that is why I didn't discuss it. You separately text me or mail me, I'll discuss it with you personally. Okay, there are at least 3 to 4 variants of Koebner phenomena, reverse Koebner phenomena, true Koebner phenomena, pseudo Koebner phenomena. We can individually discuss with separate examples of dermatological disorders. I would prefer, Trishan, that the question directly come to me on my personal front, so I'll answer the question here because not everyone may be so much going into depth of reverse Kovner phenomenon. Okay. খুব সহজ করে বলতে গেলে উল্টো দিকে কোপনারে ইনজুরি লিশনটা করে, এখানে উল্টো পার্টটা জাস্ট হয়, এটাই ইম্পর্টেন্ট।
Okay, sir. This question was from Vishadi, and Devojyoti is asking the second question: the role of smoking and alcoholism in the pathogenesis of psoriasis.
That is just a trigger factor in case of psoriasis. Amongst the trigger factors I just discussed, because they also have their immunosuppressive role, and that is very important there. Okay, basically due to immunosuppressive role. Reverse Kovner physically lesion Kovner মানে psoriasis lesionটা হচ্ছে an injury, আর reverse Kovner phenomena হচ্ছে lesionটা disappear করছে with injury. এটা হচ্ছে একদম ইন সামারি, এইটুকু জানলেই চলবে, ঠিক আছে? এটা বেসিক্যালি ভ্যাসকুলাইটিসে দেখতে পাই আমরা কিছুটা, এর বেশি আর বলবো না।
Sir, Shauvik Malik asking, sir, palmoplantar variety psoriasis can lead to severe variety of psoriatic erythroderma.
Palmoplantar variant of psoriasis usually is a localized variant. Okay. However, if people are using systemic corticosteroids in treatment of this for prolonged time, withdrawal may lead to precipitation. This is important. Erythroderma can develop here. Palmoplantar psoriasis, erythroderma transfer or chance come.
Okay, sir. A few questions from my side. When will you send the skin biopsy for psoriasis? Like any guideline for that?
Routinely, clinically, majority of the cases, you can confidently diagnose a case of psoriasis, as I have discussed following the clinical tips. In case there are some doubts, where psoriasis, eczema is a very common differential diagnosis with psoriasis. Right again, if I go back to the previous question of palmoplantar psoriasis, distinguishing palmoplantar dermatitis and palmoplantar psoriasis is quite difficult. Even seasoned clinicians find it difficult to distinguish between the two. There are some clinical pointers like pruritus, like nail changes at the other side, nail changes, psoriasis at other sites to distinguish palmoplantar dermatitis from pruritus. Where in such cases, where a diagnostic dilemma can develop, you can definitely go in for a skin biopsy to see the classical histological changes.
Yes, sir. Nail changes. It looks very similar to onychomycosis and something like that.
Onychomycosis, the fungal scraping, to dekhi the fungal hyphae.
Because it looks very similar to that one.
Are kono question?
Sir, is there any grading for psoriasis?
Definitely আছে, psoriatic area severity index, disease quality of life index, অনেক গ্রেডিং আছে। ইম্পর্টেন্স হচ্ছে পাসি স্কোর যেটা বলা হয়, তোদের জানার দরকার আছে কিনা আমি সেই জন্য অত ডিটেলস চাইনি। PASI psoriatic area severity index, পাসি স্কোর ইম্পর্টেন্ট কেন? বায়োলজিক্যালস বা অন্যান্য ট্রিটমেন্টের ক্ষেত্রে পাসি স্কোর ইন 3 distinct things. One is erythema, one is induration, one is scaly. সেটা 0 to 4 এ স্কেল করা হয়, অ্যাবসেন্ট, মাইল্ড, মডারেট, সিভিয়ার, এক্সট্রিম। এরিথিমা কত? 0, 1, 2, 3, 4 আলাদা সাইট, ইউনিট হেড, আপার লিম্ব, লোয়ার লিম্ব, ট্রাঙ্ক, 4টে সাইট ধরে এবার সবগুলো অ্যাড আপ করে একটা পার্সেন্টেজ আছে, সেটা দিয়ে পাসি স্কোর করা যায়। ওয়াই পাসি স্কোর ইজ ইম্পর্টেন্ট? ট্রিটমেন্ট আর্মামেন্টোরিয়াম যে মডালিটিস গুলো আছে, ফলোইং ট্রিটমেন্ট কতটা ইমপ্রুভমেন্ট হচ্ছে পাসি স্কোর ইজ আ ক্রাইটেরিয়া which will help you to analyze whether the treatment is efficacious. তাছাড়া ডিজিজ কোয়ালিটি অফ লাইফ ইন্ডেক্স আছে, আরো আছে নেল সোরিয়াসিস এর জন্য আলাদা স্কোর আছে, ন্যাপসি স্কোর, ঠিক আছে? এগুলো মনে হয় ইউজিতে লাগবে।
Okay, sir. Obviously, asking once again, sir, why systemic steroids are used in pregnancy in spite of being contraindicated in psoriasis?
Psoriasis in pregnancy the systemic steroids তো দেয়া হবে না।
স্যার একবার আপনি বললেন মাঝখানে সিস্টেমিক স্টেরয়েডস কিছু কিছু ক্ষেত্রে ইউজ করা হয়।
সিস্টেমিক স্টেরয়েডস বিশেষ একদম সোরিয়াটিক আর্থ্রোপ্যাথি এক্সট্রিমিয়েটে আমরা প্রথম 7-10 দিন ভেরি সিলেক্টিভ কেসে দিই, প্রেগন্যান্সি নয় রে, ঠিক আছে? ভেরি সিলেক্টিভ কেসে 5-10 দিন দিয়ে তুলে দিই। সিস্টেমিক তোর জন্য সিস্টেমিক স্টেরয়েডস ইজ নো ইন সোরিয়াসিস। ওকে
ওকে স্যার।
প্রেগন্যান্সি একদমই নয়। সোরিয়াটিক আর্থ্রোপ্যাথি 2-1টা ক্ষেত্রে আমরা দিই। মানে এইটা ব্যাপারটা কি জানিস তো, এইখানে হচ্ছে আমি স্পেশালিস্ট হিসেবে তোকে কতটা এক্সপোজার দেবো ইউজিটাই সে চিন্তা করতে করতে বলা। মাঝে মধ্যে অফপিট 2-1টা যেটা পোস্ট গ্রাজুয়েটের জন্য কমেন্ট করা হচ্ছে, ঠিক আছে?
ওকে স্যার।
আর কি প্রশ্ন বল? ত্রিশান আর কোনো প্রশ্ন আছে তোমার?
আর কোনো প্রশ্ন আছে? নাহলে হচ্ছে আমরা আজকের মতো ক্লাস শেষ করব।
থ্যাংক ইউ ভেরি মাচ স্যার।
হ্যাঁ, থ্যাংক ইউ। আর কারোর যদি ইন্ডিভিজুয়াল প্রশ্ন থাকে আমার ফোন নাম্বার দিয়ে দিস, ইমেল আইডি দিয়ে দিস, ইন্ডিভিজুয়ালি আমি তাকে ফোরামে মানে ইন্ডিভিজুয়ালি উত্তর দেবো, ঠিক আছে?
ওকে স্যার। That's so nice of you. Vijaya sir,
Thanks a
sorry,
lot,
Shubho
sir.
Vijaya,
And
no?
thanks a lot every students for joining. শুভ বিজয়া। আমাদের পরের ক্লাস আমরা হচ্ছে সাইটে আপলোড করে দেবো।
অবশ্যই অবশ্যই।
ও থ্যাংক ইউ ডক্টর জানা, থ্যাংক ইউ।
Okay, thank you.
থ্যাংক ইউ স্যার।
থ্যাংক ইউ। চলো লিভ করি তাহলে।
হ্যাঁ স্যার, গুড নাইট স্যার।
গুড নাইট, গুড নাইট, গুড নাইট।